Hi everybody, my name is Joe Crit, and today I am going to be doing my autoimmune disease report on the skin condition psoriasis. So just to start off, I'm going to talk a little bit about the characteristics of psoriasis, which you can kind of see in the pictures on the right there. So it's a chronic systemic autoimmune disorder, and it is characterized by the formation of skin plaques. These skin plaques are going to be red looking and itchy and sometimes cause lesions. And again, as you can see on the right, they're going to present themselves on the hands, elbows, also knees, at the scalp and the abdomen. And additionally, some other types of psoriasis are going to present themselves within the folds of the skin, so like under the armpits, behind the ear, or in genital creases, places like that. This is a debilitating disease. It is non-lethal. However, it is associated with various comorbidities, such as obesity, diabetes, cardiovascular problems, things of this nature. It's an autoimmune disorder, so in this disorder, T cells are going to be attacking keratinocytes, causing hyperproliferation. Some other theories as to the mechanism to this disease is that it's a genetic disease. One piece of evidence that corroborates this fact is that monozygotic twins, so identical twins, if one of them has psoriasis, the other one is 3 times more likely to also develop psoriasis, whereas this is not the case with dizygotic twins or non-identical twins. It's triggered by various environmental factors also, such as the weather. So, for example, during the winter months, psoriasis is more common just because the air is much colder, much drier. It can also be triggered by different non-specific factors. So, for example, different types of drugs can cause psoriasis or can trigger psoriasis, such as beta blockers, antimalarials. Other non-specific triggers, it can be caused by infections, such as infection with the streptococcus. So during strep, you can develop psoriasis in your throat. And then another non-specific trigger is agitation to the skin, such as scratching the skin, or when you get a tattoo, sometimes that can cause psoriasis. So a little bit about the history of psoriasis. I have a few slides on this, and if you zone off, I totally get it because this isn't always everybody's thing, but I thought it was super interesting. So the psoriasis, it starts, as most things start, with the father of medicine, Hippocrates, who describes skin disorders using words like psora and lopoi, psora meaning itch, and lopoi meaning scaly or dry. It's not entirely clear if what he was talking about was psoriasis, but some of the things he was describing had many of the characteristics of psoriasis. The next person who sort of described skin conditions which were like psoriasis was a Roman official, Cornelius Cellus, who described the skin condition which affects the limbs and the nails. This skin condition was characterized by red skin covered in scales, which sounds a lot like psoriasis, but again, he didn't coin the term psoriasis. And lastly, Galen of Pergamon first used the term psoriasis to describe itchy, scaly eruptions on the eyelids and genitals of his patient. So during this time period, and also the next time period I'm going to talk about, the Middle Ages, psoriasis and leprosy were often lumped together, and as we'll see, this had various detrimental effects. So I'm going to go ahead and talk a little bit about psoriasis in the Middle Ages. Like I was saying, unfortunately, a lot of people with skin conditions were grouped in with lepers, so this included people with like psoriasis or vitiligo. As we know, lepers were outcasts during this time. They were forced to carry a bell, a clapper, to announce their presence. And unfortunately, in France, Philip the Fair had lepers burned at the stake because they were unclean. And unfortunately, this included people with psoriasis because there was no clear differentiation between the two. So not a great time to have psoriasis. During the Renaissance, however, there was a lot of research done on skin diseases. Specifically, Girolamo Mercuriali writes De Morbis Cutaneis, Diseases of the Skin, where he describes psoriasis as lepra grecorum. This is good because he's distinguishing psoriasis sort of as a separate disease However, it is not good because since he terms it lepra grecorum, there isn't a clear distinction yet between leprosy and psoriasis. So by giving it that term lepra, he's still sort of associating psoriasis with leprosy, which is still problematic. Also during the Renaissance, Bernardo Ramazzini writes De Morbis Artificium Diatribae, or the disease of the workers. This describes various skin conditions such as eczema, dermatitis, and also psoriasis. So moving on to the 18th and 19th centuries, this is when psoriasis sort of starts to become a more distinct disease. Daniel Turner, Charles Laurie, and John von Planck write generally about skin disease. This includes psoriasis a little bit, but they don't focus on it. However, Robert Willen develops a classification of different skin diseases. He provides descriptions of various types of psoriasis, and he recognizes psoriasis as a separate from other skin diseases. However, again, he still terms psoriasis as lepra vulgaris, so we still run into the problem where psoriasis is being associated with leprosy with this official title. And it's not until Ferdinand von Hebra where he removes lepra from the description of psoriasis, and this separates the two diseases as distinct. As you can see in the pictures on the right, the top one is psoriasis, the bottom one is someone with leprosy. So they are very similar skin conditions, so it's understandable why people would lump them together or confuse them. So moving on a little bit into the incidence of psoriasis, its worldwide prevalence is 0 to 2.1% in children, and it's going to be 0.91% to 8.5% in adults. The 0.91% is in Italy, I believe, and the 8.5% is in Norway. So, and then in the United States, there's a very low prevalence. It's about 0.0408% in children and 0.0789% in adults. But take into account these percentages, they seem very low, but this is in regards to the entire world population and also the entire population of the United States. So although the percent is small, it's still a decently large chunk of the population. The mortality from severe psoriasis is 8.92%, which I found in one study. However, you need to understand that this is only mortality from severe psoriasis cases, not mortality from all psoriasis cases. And again, the highest incident, that 8.5%, is going to be in Norway. And interestingly enough, psoriasis cases are more frequent in countries which are further from the equator. Which again, I talked a little bit about environmental factors, how air that's drier or colder is usually a good indicator that there are going to be more psoriasis patients. So this makes sense that Norway, which is far north, and other countries which are further from the equator would have high levels of incidence of psoriasis. So there are 5 different types of psoriasis. The first one, what most people think of when they think of psoriasis, is psoriasis vulgaris, or plaque-like psoriasis. This affects 90% of people with this disease. So it's most common. It's mainly what people think of when they think of this disease. However, there are other ones such as guttate psoriasis, which is characterized by drop-like lesions on the skin. And erythrodermic psoriasis, this is characterized by red, blotchy skin on the for patients. Another one is inverse psoriasis. This presents itself in armpits, behind the ear, in different bodily folds and creases. And the last one is pustular psoriasis, which, as the name suggests, is characterized by pustules all over the body. So how do you diagnose psoriasis? The first thing to do is you're going to want to examine the skin, nails, and scalp for this characteristic skin condition. On the right, you can sort of see what it looks like. Some symptoms of psoriasis are going to be itchy skin, nail pain, and also joint pain. So you can develop something called psoriatic arthritis from psoriasis. What this basically is in psoriasis, the dysfunctional T cells are releasing various cytokines which have pro-inflammatory abilities, And so those inflammatory cytokines are going to be getting into joints, and they're going to be causing inflammation. This is what's going to be causing arthritis. Some other indicators that you might want to take into account when making a diagnosis of psoriasis is family history, whether or not the patient has any other people in their family who have had psoriasis, since this is a potentially genetic disease, and also any recent lifestyle changes. But as with all skin conditions, the best way is to take a skin biopsy to see if the patient has psoriasis. So the mechanism of psoriasis is largely unclear. However, we have a general idea of how it works. So some unknown antigen is going to activate Langerhans cells, and these are going to move from the skin to the lymph nodes. They're going to present this antigen, which this antigen uses molecular mimicry to sort of look like keratin. It's going to present this to T cells. The T cells are naive T cells are going to be activated by this antigen, and this is going to cause them to secrete various, like I was saying, pro-inflammatory cytokines. These cytokines are going to cause hyperproliferation of keratinocytes, so just uncontrolled replication of skin cells. And as I was saying before, this disorder is potentially genetic. The mechanism is potentially genetic. So there's a concordance rate of 63 to 73% in identical twins, and a concordance rate of 17 to 20% in non-identical twins. The suggested disease susceptibility loci for if this is a genetic disorder is source 1 and source 9. So the B cells play a pretty small role in psoriasis. It's not studied very much, but B reg cells have been shown to suppress psoriasis-like inflammation by expanding T regulator cells and by the inhibition of Th17 differentiation in psoriasis patients. This is mainly in mouse models. And also B reg cells regulate the early stages of the disease. T cells are going to play a much larger role. This disease is caused by dysfunctional T helper cells such as Th1, Th17, Th22, and T reg cells. And like I was saying before, naive T cells are going to be activated by different cytokines which are produced by antigen-presenting cells. Cytokines such as IL-23, IFN alpha, IFN gamma. And just like the B reg cells were regulating the early stages of the disease, T reg cells are going to regulate late stages of the disease. There are also some receptors that have been shown to be involved in psoriasis, the development of psoriasis. So in mice models, the deletion of IL-17RA and IL-36R have been shown to alleviate psoriasis-like symptoms. And also different cytokines which are released in psoriasis are associated with receptors such as IL-17RA, TRRA, F6, IL-36R, etc. So these receptors play an important role in the receiving cytokines in psoriasis patients. Also, a couple of innate cells are ILC3 cells, which show or appear in psoriatic lesions in blood samples. Also, gamma delta T cells and natural killer T cells. So treatment options for psoriasis, there's no cure, but there are various palliative treatments such as topical medication, systemic medication, and also light therapy. It should be known that light therapy should only be used under the direction of a licensed medical provider. There are various treatment options at home, but the best way to get the best results is to go to a, again, licensed care provider. So there's some interesting research about psoriasis, specifically on the mechanism of psoriasis. One theory is that the gut microbiome actually causes psoriasis-like conditions. There are a couple different strains of bacteria which have been shown to be related with psoriasis. And there are also the development of new treatment options which are currently being researched, such as biologics for psoriasis. And here are my references, and I hope you enjoyed it.